Hi guys, my name's Nick, and this week we'll be talking about Norway's healthcare system. The Kingdom of Norway is located west of Sweden in northern Europe and is considered one of the three Scandinavian countries. In Norway, the terrain is mostly barren, with rugged mountains, broken by fertile valleys, scattered plains, a coastline indented by fjords, and Arctic tundra in the north. Norway is considered one of the most richest countries in the world after they found oil in the 1970s. The population of Norway is 5.2 million people, and the population density is about 14 people per kilometer, making it one of the most sparsely populated countries in Europe. Norway is geographically large, and populations are very dispersed. Historically, there has been a very limited number of healthcare professionals. During this era, midwives and civil servants began playing a large role in monitoring and providing healthcare to populations. Midwives were paid publicly, which was the very beginning of a publicly funded system. Smallpox vaccinations became mandatory, and smallpox was subsequently eliminated from society. In the 1960s, TB was also eradicated. Gradually, more residents of Norway gained publicly funded insurance, and there became more of a focus on hygiene, public health, vaccinations, education, and addressing the healthcare needs of the population. After World War II, Carl Ebang and the Labour Party began working towards the vision of achieving a central and universal healthcare for the people of Norway. Now, this had a significant impact on the publicly funded healthcare system, and these ideas were largely based on the American and British systems. In the 1970s, healthcare was focused on equality and increasing geographical access to care. In 1980, the Labour Party was elected with Gro Harlem Brundtland, a physician and health researcher, as the first female Prime Minister of Norway. Healthcare reforms in the 1980s aimed to contain costs and decentralize services. The Norwegian Primary Health Services Act of 1982 decentralized services and gave municipalities responsibility for all primary healthcare services, yet the state was still in charge of legislation. In the 1990s, with Gro Harlem Brundtland and the Labour Party still in power for 3 consecutive terms, the 1990s focused on increasing efficiencies within the healthcare system. The 2000s focused on structural changes and reforms to improve the coordination of care, quality, and patient safety. During the election of 2001, the Labour Party was unable to form government, and a coalition of 3 parties was formed. Shortly thereafter, in 2002, the responsibility of hospitals was transferred to the state, with intents to control specialized services in a smaller number of health authorities, which formed the basis for Norway's current healthcare system. This reform unified political, financial, and administrative responsibility for all services in Norway. During this time, specialist care was also expanded to increase citizens' access and to decrease lost time and sick days. There also began to be more of a focus on restructuring of regional health authorities and adjusting and allocating finances. Thus, 5 regional health authorities became 4. In present times, the focus is currently on improving the coordination of care between municipalities and state-controlled specialist services. In 2012, reforms were made to improve coordination of care between municipalities and hospitals, while there was increased emphasis on public health, prevention, and social inequalities. As the leader of the Conservative Party since 2004, Erna Solberg was elected in 2013 and still remains Prime Minister of Norway today. In the same year, 2013, the White Paper was proposed with the goal of improving quality and patient care issues. The Directorate of Health is an executive agency and authority that is subordinate to the Ministry of Health and Care Services. Their vision is good health, good lives. Their public mandate is that they shall improve the health of citizens and communities by targeted activities across services and administration levels. The values of the Directorate of Health include professionalism, openness, and cooperation. These levels may sound confusing, but we'll go over it later. Moving on to stakeholders. A stakeholder is a person or party that has interest in a certain venture that can either affect or be affected by the aforementioned venture. In Norway, stakeholders include anyone who utilizes the health system. This includes the government, general public, general practitioners, healthcare workers, hospitals, researchers, non-governmental organizations, academia, and municipalities. Bohm's classification of systems introduced a taxonomy of 30 OECD countries by looking at their actors and dimensions. The actors can be at the state, societal, or private level, while the dimensions include regulation, financing, and service provision. Based on these factors, 27 total systems are possible. Of these 27 types, 10 were considered plausible, and Norway is one of them. Norway is considered to be a semi-centralized national health service type, which means that the regulation, financing, and service provision are all governed by the state. However, primary care is still the responsibility of the municipalities, making it semi-centralized. In 2015, Norway spent 10% of its total GDP on healthcare. This equates to roughly $7,343 per capita, which is much higher than most OECD countries. Sales tax in Norway is 25%, and in 2015, income tax was 39%, which was the lowest it had been in 20 years. Healthcare is paid for through these national and municipal taxes. The government provides these funds for healthcare to the municipalities and regional health authorities, who are required by law to maintain their budgets. Each regional health authority decides where these funds are allocated. The public health sector expenditure makes up 85% of the total health spending, while out-of-pocket payments and private insurance makes up the remaining 15%. Some form of private health care is utilized by approximately 7% of the population, with many employers providing this coverage.
Norway is comprised of 8 regulatory bodies. They include the Ministry of Health, Ministry of Health and Care Services, Directorate of Health, the Regional Health Authorities, the Board of Health Supervision, the Medicines Agency, the Norwegian Institute of Public Health, and the Norwegian Health Economics Administration.
The Ministry of Health is in charge of regulation and supervision of the system. They often delegate tasks to subordinate agencies such as the Norwegian Medicines Agency and the Directorate of Health. As a government agency, the Ministry of Health oversees legislation and funding. They also own hospitals and are directly involved with specialists. Lastly, they are responsible for providing directives to the regional health authorities. The Ministry of Health and Care Services are politically led by the Ministry of Health and ensure that political decisions are translated into practice. This is done through legislation, budget setting, and by overseeing subordinate governmental agencies such as regional health authorities and the Directorate of Health. Their chief responsibilities include health policy, public health, health services, municipal services for the elderly and disabled, health legislation, and some social legislation. The Directorate of Health is an executive agency and authority which is subordinate to the Ministry of Health. It implements its authority in health policy by setting national health standards, clinical guidelines, and leading in development and applications of health information technology. They oversee living conditions as well as provide public information on health and healthcare trends while providing expertise to other regulatory bodies. Moreover, they are also responsible for setting fees in the diagnosis-related group system. All in all, they are responsible for translating policies, laws, and regulations into practice. There are 4 regional health authorities that oversee 428 municipalities, and they are required to report to the Ministry of Health and Care Services. They provide primary and social care to their communities, which includes overseeing specialist care, as well as mental health and addiction services. With the new reform underway, the regional health authorities will be discontinued, and the responsibilities will be transferred to other national agencies for a better continuity of service. The Board of Health Supervision is a national public institution organized under the Ministry of Health. They perform audits in different areas of the healthcare system. They are able to issue fines to institutions as well as warnings to individual healthcare personnel. Through this, they are able to revoke authorization to practice when misconduct occurs. The Medicines Agency determines which medications to reimburse. They also determine if new medications should be covered by evaluating cost effectiveness, compared to existing treatments already in place. They are also responsible for deciding maximum pricing on medications. The Norwegian Institute of Public Health is the center for research and surveillance of the health status of the population and can provide advice on the public health to the Ministry of Health. They are the main authority regarding infection control and conducts infectious disease surveillance. The Norwegian Health Economics Administration is responsible for payments to healthcare professionals, reimbursement of medications, dental care, and out-of-country healthcare. They provide health cards and organize a general practitioner scheme. Norway's healthcare is built on universal coverage and the principle of equal access. Members of the European Union and other legal residents all receive the same coverage as Norwegian residents. Also, undocumented adult immigrants have access to emergency care, while their children receive the same coverage as Norwegian residents. Private healthcare makes up 15% of total healthcare expenditure, and those who choose to use private insurance have access to shorter wait times for care, such as elective services and various diagnostic testing services. General practitioners act as gatekeepers within Norway's healthcare system, meaning that you must see your GP before you can access any sort of specialist service.
Unfortunately, there is no concrete list of what is covered in Norway, so we put together a list of what we could find. These include planned and acute primary hospital and ambulatory care, rehabilitation, outpatient prescription drugs on the blue list, dental care services for children up to 18 years of age and other prioritized groups, preventative services for mental health, which are specifically geared towards children and adolescents through the school system, hospital admissions and all inpatient treatment, and long-term care is provided on a basis of need. There is also an element of cost sharing, or otherwise known as co-payments, for services such as GP and specialist visits for outpatient hospital care and same-day surgery, as well as physiotherapy, covered prescription drugs, radiology, and laboratory tests. Coverage does not include non-medical eye care, aesthetic surgery, and complementary medicine.
The following are areas of concern for the Norwegian population regarding healthcare, some of which are very similar to Canadian concerns. Recruitment of health personnel, notably doctors and specialized nurses, is more difficult in rural areas. New physicians are typically employed in rural areas. However, they only stay for 1 to 2 years before moving to bigger centers such as Oslo. This is a major concern in Norway because GPs act as gatekeepers to the healthcare system, and follow-up care can be disconnected. Norway's life expectancy is 82.3 years. While this is good, it also means that there is a large proportion of their population living with chronic illnesses that requires an increase in healthcare system utilization. Similarly to Canada, long wait times for elective care is also a major concern, with elective and specialist wait times that are only slightly better than Canada's. Mental health services, while improving, are still a major concern of citizens as the country has a high rate of suicide. The Norwegian people felt that they were not receiving optimal care and asked the government for more transparency and accountability. This was evident when we found a study that suggested that 42% of the population said that fundamental changes are needed to improve healthcare, while 12% felt that the entire system needs to be completely rebuilt. The population is questioning the current policies as well as patient safety and quality of care. Furthermore, care coordination has also been a concern. These concerns have led to the government initiating the care coordination reform, which began in 2012 and is still being implemented today. This will see the regional health authorities disappear in an attempt to improve the coordination of care. Norway faces the challenge of providing healthcare for the aging population. By 2040, the percentage of people 80 years and older is expected to double, which increases the demand for healthcare services. To further add to this challenge, length of hospital stays are dropping and discharge rates are rising. The average length of stay has dropped from 8.6 to 6.8 days due to an increase in acute care needs. This increases the pressure on the community and primary care services, resulting in a high demand for more primary care services and healthcare professionals. Norway spends a lot of money on healthcare, but still lacks quality of care in some areas such as palliative care, long-term care, and mental health care. 54% of doctors feel prepared to manage patient needs in palliative care, while 78% of doctors feel prepared to manage patients in long-term care and home care services. Like in Canada, the distribution of health services presents a special challenge in the Norwegian healthcare system, as the country is geographically large and the population is dispersed. Major hospitals are typically located in urban areas, and nearly all of the tertiary level hospitals are situated in major cities. This requires extra travel time for patients living in rural areas. Travel time can also be difficult because of the rugged landscape and many fjords. Eliminating these inequalities in rural areas is a priority for the Directorate of Health. In addition to the policy issues, the organization of the regulatory bodies is also confusing. As previously mentioned, Norway has at least 8 government or national bodies overseeing healthcare. This leads to overlap as well as some issues slipping through the cracks. A major part of the coordination reform beginning in 2012 will hopefully see this issue resolved. As you can see, there is no real hierarchy or succinct structure, which poses problems with role clarification and distribution of services. Our Norwegian correspondent, Ronheld, who has lived in Norway most of her life, discusses a personal barrier to healthcare, which has been corroborated with what we have read in various articles. Currently, in regards to healthcare in Norway,
it's internal communication between the health givers, so that one department, one person, one hospital knows what the other one is doing with you, because that seems to be a problem. Because if you are, I have seen, and that is personal experience, not my own personal experience, but I've seen that if you are in the system and you have several things, several places within the healthcare system that you need to use, then it doesn't always work. Then you have to be your own coordinator. You have to sort of, be healthy to be sick.
Yeah.
Because you have to be able to keep up and be your own coordinator. That seems to be a big, something that really needs to be worked with.
Our Norwegian correspondent, Ronheld, believes that our healthcare needs are being met. However, she feels that there are certain areas that are in need of improvement. These include wait times and the coordination of care, in particular, internal communication between healthcare providers. We found that 66% of primary care physicians felt they often or always received information regarding their patients from specialists, and that this information was adequate. According to the Commonwealth Fund, 46% of Norwegians believe the healthcare system works well with only minor changes needed. As previously mentioned, 42% feel that fundamental changes are needed, while 12% believe that the entire system needs to be completely rebuilt. Juxtaposing the population and primary care physicians, 67% of physicians felt the system works well with only minor changes needed. According to the OECD, Norway is performing well across all of its indicators, which means that Norway is meeting its population's health needs. All in all, Norway's healthcare system is one of the best in the world, and they spend a generous amount of their GDP on healthcare relative to other OECD countries. However, they need improvements in rural care, decreasing wait times, enhancing internal communication, more services for mental health, and the increasing burden of the elderly population. Therefore, we have determined that Norway is partially meeting the needs of its population, as it can always get better. Thanks for watching, and feel free to ask any questions.